Thank you so much, Patty. I do want to go ahead and I'm not going to read any of the case studies, but I don't have any disclosures either. They are part of the handout, so I'm not going to read through all these, but as we go forward in the talk, we are going to incorporate these into our talks. So just to let you know, we will be based on these cases. Now, the next slide is our treatment algorithm. And I know that everybody has a different treatment approach, and there are no right or wrong, and I apologize for the small print, but this is in the handout. We do have a full-page version of this in the handout that you can download for this session. So I just wanted to let the group know that this is our treatment algorithm. There are several guidelines and other types of approaches for fecal incontinence, but I want to orient you to the center of this, where this is actually where we really want to start the treatment. And the part that I'm going to be talking about today is this multi-component behavioral therapy. We do feel the importance of, as Dr. Good mentions, both diarrhea and stool consistency in the management, and assessing all the things that could be contributing potentially to the diarrhea. And then also on exam, it's very important, as she said, to address the anal sphincter strength. And if on exam, the strength is not where a person should be, or if you feel weakness, that might trigger you to get further testing with anal rectal manometry or endoanal ultrasound. So it's not that everyone with fecal incontinence who walks in the door needs these tests, but we do feel strongly that on exam, if there's something that makes you think that they may not respond to some of the treatments, that might be a good reason to send them for further testing and evaluation, because treatments differ based on these findings. But again, you may try also these conservative first-line treatments first, and then if they're not improving, as this algorithm states, they would go back up and at that point consider testing and looking for other things. At the end of this, I do have a section in our algorithm that talks about refractory. So once you've tried those first-line conservative treatments, we're going to touch on not only the surgery, but some of the other newer treatments there. And then we don't really have, in my opinion, a good line of a treatment approach of what to do in order. However, I am going to talk a little bit about the anal injectables and posterior tibial nerve stimulation. So focusing now on those conservative first-line treatments. Again, with all treatment, it really is important to consider your patient preferences. It's really important to know the history of where they've come from. What have they tried? What have they not tried? What's worked in the past? What hasn't worked? And so all of these are very dependent on where that patient comes from in the setting and when they're being referred and what kind of treatments they have had already. But these are the main categories that I've divided this into some lifestyle changes, our behavioral treatments, including pelvic floor muscle exercises, medications when appropriate, even devices. I'll talk a little bit about that, and then the office-based procedures. So behavioral approaches, this is just another way of looking at these, but we consider all of these behavioral approaches to the treatment of bowel incontinence, starting with diet and fluid management, very important. Behavioral strategies, how to control that urgency, pelvic floor muscle training and exercise, kind of the cornerstone of the treatment, and then biofeedback when appropriate to influence and really focus on the strength and other sensory components of training. Bowel diaries. Keeping a bowel diary throughout of this can be very helpful for the patient and the clinician. And then weight loss when appropriate, and then bowel training for certain patients, and really focusing in on normal bowel habits. So I'm going to start with a little bit of evidence that we have for some of these treatments. And I'm going to start with weight loss. What do we know? Now, I don't list all the studies here, but there's several studies that really talk about the improvements in not only urinary incontinence, but also bowel incontinence after gastric bypass or other weight loss surgeries. And you can see that within a year after having a surgery with significant decreases in body mass index and obesity, you can really decrease fecal incontinence. This is also true if you actually, we did a secondary analysis in a randomized controlled trial with a primary goal of reducing urinary incontinence through diet and exercise. And by looking at the secondary fecal incontinence severity in this trial, even though this wasn't a trial just to improve fecal incontinence, that sure enough, independent of the type of diet or exercise done, that by weight loss alone, you do improve fecal incontinence severity. And then our other behavioral treatments, pelvic floor muscle exercises, bowel control strategies, prompted voiding in fecal incontinence, and biofeedback. You know, not all of these have strong evidence alone, so we talk a lot about these, about the evidence in combination. So I'm going to try to break this down a little bit and talk about that. But before I do, I wanted to talk about our approach. Our pelvic floor muscle training program is really what we do when we not only examine the patients, we teach them rectal muscle exercises or pelvic floor muscle exercises during the exam. We often talk about the importance of doing these exercises over time. And it's very important to not only focus in on just the proper isolation of the muscles and relaxation, but also the duration of the contraction and doing this in a repetitive way and doing it in an organized fashion with a varying in position. We also talk about bowel control suppression techniques. These are for people with the urgency, how to control that urgency. Urge suppression, one of the common terms is walk, don't run in the literature. And other bowel techniques, it's more difficult when you think of passive fecal incontinence to use these, but passive is being hypervigilant to any bowel sensations, to really not ignore anything that's felt from the rectal area. And all of this is the importance of self-monitoring with diaries. And then biofeedback. This is really not alone an intervention in my mind. It's a teaching tool. It amplifies the muscle control and strength, and you also have different protocols based on your goals. So you really have small physiologic responses that are usually amplified, whether it's using EMG techniques or manometric catheters inside of the rectal area themselves, and it's a display. So it's a visually appealing display that a patient can use and a therapist or a clinician can use to help reinforce improvements, behaviors, and they really are seen as a coach. So it involves, in my mind, the foundation is the motor control or that strength training. And then layered onto that are the sensory protocols, where we have protocols for both passive or urgency leakage, and urgency would be a hypersensitive protocol and a hyposensitive protocol for passive leakage. And then the combination thereof, or coordinated training, is both using the motor and sensory. Here's a picture, and let me just orient you this. This is a picture that Dr. Gooch showed of the tablet device. This is an easy touch screen. This is involves the use of a manometric catheter. So these lines that are portrayed on this is actually coming from a manometric catheter approach. You can see on the left-hand side of this over here that this also does manometry. So you go through manometry, looking at both resting and squeeze pressures, but the bottom left portion of this, and I'm going to apologize, is the pelvic floor training or biofeedback portions. And this is a picture of the strength protocol, but you can see here we also have protocols for sensory and urge resistance. So for the patient, this is a screen they would see, and you see the pressures at the anal sphincter, at the rectum, and you can see here that the first squeeze pressure is you have a target goal. You're really not only monitoring the strength, the duration of contraction, but also correct muscle isolation. So you can see that first contraction, they were using more other accessory muscles. You're recruiting other muscles where you focus the strength only or that contraction on the anal sphincter muscles, and you really don't want to move the rectal catheter or that balloon that's in the rectum. So this is biofeedback in one modality. All right, so the evidence behind that. So we know that there are many studies. Biofeedback is not a new modality. It's been there and been in practice for years. But what I want to do is just kind of summarize that there are really there's several key studies, but I'm presenting 3 here of randomized controlled clinical trials, 2 of which are single site, 1's multi-center, and they all really kind of show some mixed results. So of these trials of biofeedback, the Norton et al. From 2005 showed that biofeedback done by a clinician in the office-based setting was no better than a actual just education program and a booklet, as well as including in all of these diet modifications and treat with medications if indicated. Dr. Heyman and Bill Whitehead from UNC's single sites trial they actually did a specialized trial where they first did diet management, did a run-in period. Anyone who didn't improve were either randomized to biofeedback or just exercises alone, where they showed that the biofeedback actually improved fecal incontinence episodes over exercises alone in that trial. And then there were another trial. So the next 2 slides I'm going to present talk about some combination treatments where this is biofeedback, a randomized trial of biofeedback plus an EMG home modality, so EMG stimulation versus biofeedback alone as a multi-site trial. And electrical stimulation is really thought to increase outlet pressure and decrease urgency. And again, it's also a good teaching tool for proper pelvic floor muscle contraction. And when combined with biofeedback, there were actually increased improvements in fecal incontinence over the biofeedback alone. And just in all of these trials, the reported improvement has wide ranges. But if you really look at the majority, mostly quoted and in the reviews is that biofeedback isn't 100% effective in all people, and you get a range, somewhere between 50 and 80% improvement. All right, I'm going to switch gears a little bit because I really wanted to talk about one additional behavioral treatment that involves our very frail elderly. And even though this patient case isn't a very frail older woman, she's 75 years old. Let's say she has mild to moderate dementia. She's constipated predominantly. She goes every 3 to 4 days with a bowel movement that's very hard. Laxatives, over-the-counter stimulant pills, they actually cause more problems in her with diarrhea, and that diarrhea results in bowel leakage. She really doesn't want to wear pads or pull-ups, and the caregiver's really struggling and comes in. And so I wanted to say we don't have a lot of evidence on the outpatient setting of what to do, but we do have some evidence that can help here with this patient case. And even though this nursing home study was based in prompted voiding for urinary leakage, they found that actually fecal incontinence improved. And so Dr. Schnelly and colleagues did a study, a multi-site study in 4 different nursing homes, and actually did Q2-hour prompted voiding, taking people to the toilet, recognizing bowel signals. They did some fitness exercises. They included making sure people had fiber snacks, fluid. And the outcome, even though they did incontinence checks, they did not really see an improvement in fecal incontinent episodes. These patients actually had more bowel movements. They were less constipated and had overall more continent bowel movements. So there is some evidence to suggest that if we really pay attention to bowel habits and bowel prompting, that maybe you can actually improve some of the symptoms, or at least the underlying symptoms, which really deserve treatment first, which is the constipation. And so now I'm going to switch and really talk more about the dietary changes, fiber supplementation, and medications. Again, you've seen this slide before, the Bristol Stool Form Scale, and looking at data, cross-sectional data from NHANES here in the United States, all people in that study looked at the most common type, and even though this is a rough estimate, we usually say we want to get people in the type 3 to 5 range. This is quote unquote majority of the people in the US fall within this range. And that brings us to another case. This is a 70-year-old, recent heart attack or myocardial infarction. He's actually really been trying to lose weight, eating more healthy, eating fiber cereal, skim milk. He's also doing some sugar-free candy. He's overweight. Bowel movements are soft and mushy with these new dietary changes, and he really describes more passive leakage with fecal smearing. And occasionally, he has some stool loss on the way to the bathroom with urgency. What are some treatment options? How would you approach this? And again, going back to that algorithm, I would really try to look at the potential causes. What's the change that he's done that are contributing to his loose stools? You might consider, and I often ask about lactose intolerance, malabsorption syndromes, highly prevalent in certain racial ethnic groups. Fructose intolerance, this can be specifically in people with irritable bowel syndrome, and then gluten sensitivity or gluten enteropathy. So diet really does matter and can really impact stool consistency. Oftentimes we'll also hear bile acid salt malabsorption. So you typically get a story of having a gallbladder removed. People have changes in their actual stool consistency, and that's often diarrhea due to bile acid salt malabsorption, spicy foods, fatty foods, and then just some people, for whatever reason, dietary fiber will just completely, the more fiber they eat, the more difficult it is for them to maintain stool consistency. Now I'm going to talk a little bit about fiber, actually. So not all fiber is created equal. Now this is a rough chart, and I really wanted to point this chart out to you because there's some evidence that on different types of fiber, but the differences here are the naturally occurring fibers versus the synthetic fibers. And you can see that not all fiber bulks stool. The content of the actual fiber in any dose of any of these preparation differs as well. And so that brings me to a really well done study by Bliss and colleagues about fiber supplementation specifically to treat fecal incontinence. The single-site RCT, 189 participants, and people were randomized to receive three types of fiber and placebo, and they had special nutrition people who actually baked muffins that had the exact components of all of these fibers in the muffins, and they showed that they significantly improved stools by the addition of fiber on a 7-day diary for the psyllium and guar gum, but did not have any improvement on methylcellulose. So it's very interesting to see that not all fiber is created equal. And most eloquently, she actually did stool samples and looked at the gelling property of the stools from these participants and showed that the psyllium was more likely to cause gel in the bulking product in the stools themselves. And that brings me to the last patient case I'm going to discuss is a 75-year-old who has had fecal incontinence, not for years and years, but just a year. It really has interfered with her quality of life. She really is continent usually when she had solid stool, but any kind of diarrhea causes problems. She has very little warning. And because of this, she's really started staying home. She's afraid to go out. It doesn't happen every day. It's very embarrassing for her. And what would we do in this case? This is someone who we might start fiber on, or we could consider other treatment options. And so I'm going to talk a little bit about these other treatment options. The pharmacologic treatment, there are several trials out there. There are 3 placebo-controlled trials for loperamide, and loperamide was superior to placebo in all these studies. Overall, the side effects of loperamide, including constipation, was greater. However, when there was one trial who compared loperamide to diphenoxylate atropine, showing that it actually had less side effects and actually had equal improvements in fecal incontinent episodes. And all of these are fairly small studies, and that brings me to this, which is some of the newer evidence, really looking at the addition. Does fiber, after you've already started loperamide, make any improvements? One placebo-controlled crossover trial There was no additional improvement by adding fiber when someone was already on loperamide. And then there was another study looking at loperamide versus fiber in a placebo-controlled randomized controlled crossover trial. However, it was both improved with no between-group differences. So given for 12 weeks, fecal incontinent episodes improved in both groups, and how there were less significant side effects, surprisingly, on the psyllium fiber versus the loperamide in terms of constipation and actually abdominal pain. Cholestyramine. Talk about the bile acid salt malabsorption. Cholestyramine, a drug we give for cholesterol lowering, binds bile acid salts and can have a really good effect, but we don't really know all the evidence yet. And in a case series, it actually, when added to biofeedback assisted behavioral therapy, really improved fecal incontinence episodes. So this would be an area that needs further investigation. And clonidine, someone thought that by mechanisms to the alpha properties of clonidine to improve rectal urgency. They actually did a small pilot RCT, but no improvement in fecal incontinent episodes versus placebo. And I'm going to talk about the more invasive. So we've kind of talked about all those conservative first-line therapies. What's the evidence? I can't really tell you there's an exact line by line. We sometimes give all of those in combination, but we start thinking about other treatment options when those don't work. So when we try those first-line treatment options, I wanted to let you know about some additional studies and the evidence behind them. A vaginal bowel control system, the Eclipse system, you can see by the picture there. It's a vaginally inserted device that you inflate and you put pressure in the posterior wall of the vaginal area. So again, this was a trial in women who came in with fecal incontinence, and looking at those, almost 80% had a 50% reduction in fecal incontinent episodes with this device over the intervention period. And also quality of life significantly improved. And then we all have probably heard about anal injections. They've been out for a long time, but the newest agent, the dextrometer microspheres with hyaluronic acid, they did a randomized controlled trial using this agent and also compared it to a saline injection placebo, large sample size, and compared to the placebo, there was a greater improvement in the 50% reduction rate in fecal incontinence episodes for the injection. Overall, there were fairly low complication rate with these injections, and then more recently, they compared the actual injections of this to a biofeedback intervention in a randomized trial and showed actually equal improvements for the injection to the biofeedback in patients who had never had either treatment before. All right. And then I'm going to end on a few more newer studies, very new actually, just out in the last few months. And these unfortunately didn't make the handout that we turned in last June, but we're glad to have them involved here. There is currently a adrenaline receptor agonist, an alpha adrenaline receptor agonist suppository that's being tested, and the authors have published their trial, not the results, but just the methodology. You can see there that we hope to have some evidence soon on this suppository. Anal insert devices or anal plugs. This can be very effective for some people, especially with passive leakage of trying to contain or that seepage. The Renew product is what the trade name is. There's much improved design over some older types of anal plugs. It's a very flexible silicone insert. It's disposable, and you can see up to almost up to 2/3 had a 50% reduction in fecal incontinent episodes in a trial where they just looked at pre-post outcomes. And at least almost 80% of those who completed the study were very or extremely satisfied with the results. So they had very few adverse events, well tolerated, and improved fecal incontinent episodes. Lastly, the percutaneous tibial nerve stimulation, or PT&S. This was initially made for urgency or overactive bladder. And when using through the same mechanisms by stimulation of the tibial nerve, reflexively stimulate the nerves controlling the sacral nerves to the bladder and or bowel. They did not, in this recent trial that was just published in 227 people, see any improvement with PTNS versus sham. So a sham stim versus an actual posterior tibial nerve, or the percutaneous tibial nerve, and it is not currently FDA approved in the US. And then lastly, this is an ongoing trial. You can see this on clinicaltrials.gov. This is called CAPABLE. It's a randomized controlled trial, 7 clinical sites. You can see the 4 arms there. So you're looking at biofeedback versus loperamide, and this is all women. And the comparison group is a usual care and a placebo pill. The treatment for 6 months. Primary outcome is actually the change in FI severity on the St. Mark's or Vasey scale, and the recruitment began almost 2 years ago, or a year and a half ago, and we hope to have results in the next year.